Welcome to this video entitled Inflammatory Bowel Disease. Inflammatory bowel disease, abbreviated as IBD, is a generic term used to describe two main chronic inflammatory conditions of the gastrointestinal tract: Crohn's disease, abbreviated as CD, and ulcerative colitis, abbreviated as UC. Although these conditions are similar in clinical presentation, Crohn's disease is a chronic inflammatory disease characterized by transmural lesions located at any point on the gastrointestinal tract, whereas ulcerative colitis is a chronic disease consisting of mucosal inflammation limited to the rectum and colon. Inflammatory bowel disease affects approximately 1 million Americans. In 2004, the prevalence of Crohn's disease was estimated to be approximately 359,000, and for ulcerative colitis, it is estimated to be 619,000, according to National Institute of Diabetes and Digestive and Kidney Diseases in 2010. The incidence of ulcerative colitis has been relatively stable over the past 5 decades, whereas the incidence of Crohn's disease is rising, according to Kornbluth and Sacker in 2010, and according to Lichtenstein, et al. 2009. Both conditions are more common in whites than in any other race, and those of Jewish descent have a 3 to 6-fold greater incidence than the non-Jewish population. Inflammatory bowel disease shows no gender predilection and is usually first diagnosed in men or women between ages 15 and 25, according to the American Gastroenterological Association, AGA, in 2001. Although the mortality rate is low for the disease, it significantly affects the patient's overall mental status, physical health, and quality of life. The most common emotional issues surrounding uncontrolled inflammatory bowel disease appear to be anger, frustration, depression, and low self-esteem. These issues usually stem from the patient's inability to participate in routine activities, leading to a decreased quality of life. The disease has a negative impact on social interactions and daily functional status, leading to decreased productivity and attendance at work or school, decreased social engagements, and loss of independence. Health-related issues mirror those related to poor gastrointestinal absorption, including nutritional deficiencies, electrolyte abnormalities, dehydration, cachexia, and iron deficiency anemia. Fatigue and lack of sleep are also common in patients with inflammatory bowel disease. In addition, patients with long-standing Crohn's disease may also be at risk for adenocarcinoma of the gastrointestinal tract, according to Pedersen and colleagues in 2010. All of these may result in frequent hospitalizations, altered lifestyle, and poor general health. Overall, in 2004, inflammatory bowel disease had an estimated financial burden of $328 million in indirect healthcare costs and over $1.8 billion in direct costs, according to Everhart in 2008. We will now discuss the causes of inflammatory bowel disease. The etiology of Crohn's disease and ulcerative colitis is related to the dysregulation of immunologic mechanisms. The inflammatory nature of the condition has led researchers to believe that an autoimmune mechanism may predispose patients to inflammatory bowel disease. The development of inflammatory bowel disease may be attributed to a defect in the gastrointestinal mucosal barrier that results in enhanced permeability and increased uptake of pro-inflammatory molecules and infectious agents. Tissue biopsies of the gastrointestinal mucosal lining from patients with inflammatory bowel disease reveal a high proportion of immunologic cytokines, including tumor necrosis factor, abbreviated as TNF, leukotrienes, and interleukin-1 abbreviated as IL-1. A few bacterial and viral organisms have been associated with disease progression, including Mycobacterium paratuberculosis, measles virus, and Listeria monocytogenes. However, none has been definitively correlated with inflammatory bowel disease. Much of the recent evidence suggests that inflammatory bowel disease is a complex genetic disorder. The high incidence of inflammatory bowel disease in the Jewish population supports a genetic component of the etiology of Crohn's disease and ulcerative colitis. A study comparing relatives of patients with inflammatory bowel disease with the general population found a 10-fold increase in risk of development of inflammatory bowel disease in those with familial occurrence. In addition, studies in twins support the notion that the disease course and occurrence of Crohn's disease is genetically influenced, according to Harverson and colleagues in 2007. Recently, the NOD2 CARD15 gene has been associated with Crohn's disease. Those who carry 2 copies of the risk alleles have been noted to be at higher risk for developing Crohn's disease than others. The relationship between inflammatory bowel disease and other genetic mutations and polymorphisms is currently being investigated. Until there is sufficient data to link a specific genetic mutation to inflammatory bowel disease, the identification of genetic polymorphisms remains a research tool and not a clinical diagnostic tool. Other factors, including psychological well-being and environmental triggers, may contribute to the exacerbation of inflammatory bowel disease, although these factors do not have a predictable effect over a large population. Various studies have associated isolated mental instability or stressful events with inflammatory bowel disease exacerbations, but a positive correlation between psychiatric illness and inflammatory bowel disease is unsupported. Environmental factors, including geographic location, dietary habits, drug-induced factors, and smoking status, are theorized to affect Crohn's disease and ulcerative colitis exacerbations. Inflammatory bowel disease is more prevalent in the northern parts of the United States, as well as in England and Scandinavian countries rather than the Mediterranean countries, suggesting that temperature or weather patterns may have an impact on Crohn's disease or ulcerative colitis. Various dietary habits such as high sucrose consumption have been identified as exacerbating Crohn's disease or ulcerative colitis, but no one particular food or group of foods seems to have a reliable effect in a large population. Oral contraceptive use and cigarette smoking have variable effects on Crohn's disease versus ulcerative colitis. Oral contraceptives and nicotine have been found to exacerbate Crohn's disease, but not ulcerative colitis, according to Loftus in 2004. In addition, recently, the use of the anti-acne product isotretinoin, marketed as Accutane, has been associated with the development of inflammatory bowel disease. The exact mechanism by which isotretinoin may cause inflammatory bowel disease is unknown. However, isotretinoin does affect many immunologic mechanisms that may trigger inflammatory bowel disease, according to Reddy and colleagues in 2006. Pause the video and carefully scrutinize Table 31.1 summarizing common signs and symptoms of Crohn's disease versus ulcerative colitis before advancing to the next slide. We will now progress to the pathophysiology of inflammatory bowel disease. Differentiating Crohn's disease from ulcerative colitis is difficult because of their similar clinical presentations. Hallmark symptoms of inflammatory bowel disease are bloody diarrhea, weight loss, and fever. Generally, Crohn's disease can be distinguished from ulcerative colitis based only on endoscopic findings. The gastrointestinal mucosal lining in Crohn's disease is usually characterized by discontinuous, narrowed, thick, edematous, leathery patches with the presence of lesions, ulcerations, fissures, strictures, granulomas, and fibrosis. Fistulas and abscess formation occur most commonly in patients with deep transmural lesions. Granulomas and fistulas usually occur exclusively in patients with Crohn's disease. Ulcerative colitis usually affects the rectum and areas proximal, possibly extending throughout the entire large intestine with continuous, superficial uniform inflammation and ulceration. Other pathologic findings are rare in ulcerative colitis, but may occur in patients with chronic, long-standing inflammation, as shown in Table 31.1. Extraintestinal complications, including skin malformations, liver disease, joint deformities, and ocular manifestations, may also occur, although they are more common in Crohn's disease than ulcerative colitis, because of the more aggressive nature of Crohn's disease, resulting in a higher probability of malabsorption of nutrients. See Table 31.1. Because the complications affect a variety of organ systems and result in nonspecific complaints, it is difficult to associate the complaints with Crohn's disease or ulcerative colitis. However, it is important to be aware of the complications because their presence indicates poorly controlled disease. Next, we will discuss the diagnostic criteria of inflammatory bowel disease. Because the clinical presentation of patients with Crohn's disease or ulcerative colitis is nonspecific, definitive diagnosis relies on endoscopic or radiologic studies. Initial diagnosis of inflammatory bowel disease must rule out other causes of bloody diarrhea such as infectious causes and other colitis conditions. Visualization techniques must be used to differentiate Crohn's disease from ulcerative colitis, because of their similar clinical presentations. Usually, endoscopic techniques are preferred over radiographs and radioactive isotopes, because endoscopy permits direct visualization of the mucosal lining with increased specificity as to the extent of lesions, ulcerations, and inflammation, as well as providing the opportunity to obtain mucosal specimens for biopsy and further evaluation. The risk of mucosal perforation, however, may limit the use of endoscopic technology in patients with severely active disease. Sigmoidoscopy or colonoscopy is preferred as a first-line diagnostic procedure. However, for Crohn's disease, an endogastroduodenoscopy may also be required to visualize the upper gastrointestinal tract. Radiologic studies with contrast, including either an upper gastrointestinal series or barium enema, may be preferred in patients with severely active symptoms to decrease the risk of mucosal perforation. Antibody tests are sometimes helpful in determining the diagnosis of Crohn's disease or ulcerative colitis. The perinuclear antineutrophil cytoplasmic antibody, abbreviated as p-ANCA, and/or the anti-Saccharomyces cerevisiae antibody, abbreviated as ASCA, tests may be positive in patients with inflammatory bowel disease, but there is a significant rate of false negative results, since only 60% to 70% of patients with Crohn's disease or ulcerative colitis are actually antibody positive, according to Kornbluth and Sacker in 2010. The combination of a positive p-ANCA and a negative ASCA may indicate the presence of ulcerative colitis, whereas the opposite may indicate Crohn's disease. However, the combined result still has a significant percentage of false negatives. Therefore, these tests are not used routinely to differentiate ulcerative colitis from Crohn's disease. Pause the video and carefully scrutinize Table 31.2 summarizing working definitions of Crohn's disease activity before advancing to the next slide. Pause the video and carefully scrutinize Table 31.3 summarizing the criteria for severity of ulcerative colitis before advancing to the next slide. Next we will look at initiating drug therapy of inflammatory bowel disease. Crohn's disease and ulcerative colitis share many clinical characteristics with pseudomembranous colitis, irritable bowel disease, peptic ulcer disease, abbreviated as PUD, traveler's diarrhea, colon cancer, and hemorrhoids. Evaluation of patients with suspected inflammatory bowel disease must include a complete history focusing on recent use of antibiotics, recent international travel, diet history, use of laxatives or antidiarrheals, frequency and quality of daily bowel movements, history of peptic ulcer disease, and family history of inflammatory bowel disease to rule out similar presenting conditions. Physical examination should include assessment of vital signs and weight loss, a thorough abdominal examination, and special attention to extraintestinal complications. Guaiac testing and stool cultures may be helpful in ruling out peptic ulcer disease or infectious causes. Although there are no reliable surrogate laboratory markers that may indicate the presence of Crohn's disease or ulcerative colitis, baseline laboratory studies, including electrolytes, liver panel, complete blood count, abbreviated as CBC, and hematology panel, are important in assessing the severity of the condition and patient well-being. Initiation of proper drug therapy is based on the severity and extent of disease. Crohn's disease may present as luminal or fistulizing disease. Crohn's disease confined to the gastrointestinal lumen can initially present as mild, moderate, or severe disease and is not predictable in its course. Fistulizing disease also has a varied clinical course, whereby certain patients may never experience a fistula and others may develop one early in the course of the disease. Treatment of fistulizing disease is typically more aggressive than luminal disease and may vary depending on the location of the fistula, bowel to bladder, bowel to skin, etc. UC may be confined to the distal colon and rectum or may extend throughout the colon. Due to the location of the disease, treatment options for distal ulcerative colitis are greater than for extensive disease. The working definitions of Crohn's disease activity or the criteria for severity of ulcerative colitis may be used as a guide to determine severity, as shown in Table 31.2 and Table 31.3. Both scales are frequently used in clinical trials. However, they are modified for use in clinical practice. There are many validated scales used to assess the severity of ulcerative colitis. However, there isn't one gold standard. Each scale highlights specific subjective and objective parameters that should be evaluated when assessing the progression of disease. Both scales highlight certain key features when predicting the severity of the condition, such as the frequency of stools per day and the presence of abdominal pain, fever, and anemia. Treatment for inflammatory bowel disease consists of aminosalicylates, corticosteroids, immunosuppressive agents, antibiotics, and biological agents. The decision to use one or a combination of these agents is based on the presence of Crohn's disease versus ulcerative colitis, the severity of the disease, and whether treatment is targeted at active disease or maintenance of remission. In general, aminosalicylates are used for treating mild to moderate exacerbations of ulcerative colitis and Crohn's disease, as well as for maintaining remission in inflammatory bowel disease. Corticosteroids are used to treat acute exacerbations and should not be used chronically to maintain remission. Immunosuppressive agents are used for the purposes of maintaining remission in inflammatory bowel disease, whereas intravenous cyclosporine is used in a limited population to treat severely active, steroid-refractory ulcerative colitis. Antibiotics are reserved for treating and maintaining remission in patients with mild Crohn's disease. Biologic agents are reserved for inducing and maintaining remission in patients with steroid-refractory Crohn's disease. Infliximab is the only biological agent that has proven efficacy in managing patients with ulcerative colitis, as shown in Table 31.4. We will now discuss the goals of drug therapy. Because no pharmacologic cure is available for Crohn's disease or ulcerative colitis, the goals of treatment focus on symptom management and quality of life issues. With proper treatment, the patient should be able to 1. Resume normal daily activities. 2. Restore general physical and mental well-being. 3. Attain appropriate nutritional status. 4. Maintain remission of disease. 5. Decrease the number and frequency of exacerbations. 6. Decrease side effects related to medications. And 7. Increase life expectancy. Ideally, patients should expect to recover from an acute exacerbation within 2 to 4 weeks, have minimal exacerbations throughout the year, and participate in any desired activity. Next we will discuss the aminosalicylates. Aminosalicylates remain the gold standard for the treatment of mild to moderate Crohn's disease and ulcerative colitis. Although the exact mechanism of action is unknown, these drugs decrease inflammation in the gastrointestinal tract by inhibiting prostaglandin synthesis, which results in a decrease in various immune mediators, including IL-1, cyclooxygenase, and thromboxane synthase. Therapy with these agents may improve symptoms within 1 week of initiating therapy or dosage adjustment. However, patients may need to take these agents long-term to prevent exacerbations. Although they are safe for use in most patients, aminosalicylates are contraindicated in patients with aspirin allergy or glucose 6-phosphate dehydrogenase deficiency. Sulfasalazine is also contraindicated in patients who are hypersensitive to sulfur products. See Table 31.4. All of these agents must be used at maximum doses for maximum therapeutic benefit, although the incidence of side effects also increases with increased doses. Next we will discuss sulfasalazine. Sulfasalazine, marketed as azulfadine, or azulfadine EN, is efficacious and cost-effective for Crohn's disease and ulcerative colitis therapy, but has a limited role because of its unfavorable side effect profile. Sulfasalazine is a combination product that is cleaved in the proximal colon by bacterial azoreductases to release sulfapyridine and mesalamine. The mesalamine compound is responsible for virtually all of the therapeutic effect, whereas sulfapyridine is responsible for many of the side effects associated with sulfasalazine. Sulfasalazine may be administered up to 4 times a day. The most effective and maximum daily dosage is 8 grams daily. Next we will look at mesalamine. Mesalamine, marketed as Asacol, Roarsa, Pentasa, Lialda, Apriso, and Canasa, is available in various formulations, including oral tablets, oral capsules, enemas, and rectal suppositories. Each formulation is released in various areas of the gastrointestinal tract, allowing for targeted drug therapy. However, in clinical trials the capsules and tablets had similar efficacy at equivalent doses. Asacol, which is one of the oral tablet products, is formulated with an acrylic resin coating that disintegrates at a pH of 7. Allowing the active ingredient to be released in the distal ileum and colon. Similarly, Lialda, another oral tablet formulation, has a coating that disintegrates at a pH of 6 to 7, and the core of the tablet forms a matrix that is released across a pH of 6.8 to 7.2. Pentasa, which is a sustained-released capsule, has ethyl cellulose-coated granules that allow for the slow release of the drug beginning in the proximal small intestine and continuing throughout the colon. This formulation has slightly different pharmacokinetics than Apriso, which is also a delayed-release capsule. Apriso capsules are enteric coated. They disintegrate at a pH above 6 and also contain granules that are formulated in a polymer matrix for extended release. Because each of the oral products has different pharmacokinetics, the dosing interval for the products ranges from once to 4 times a day. See Table 31.4. The rectal suppositories are used primarily for ulcerative colitis-associated proctitis, whereas the enema delivers mesalamine to the distal and sigmoid colon. The enema is typically given at bedtime to allow for direct contact of the drug with the mucosa for at least 8 hours. In patients with distal ulcerative colitis, a combination of oral and rectal mesalamine may be an appropriate therapeutic option. Studies have shown that combination mesalamine therapy is more effective than either single mesalamine formulation. We will now progress to olsalazine. Olsalazine, marketed as Dipentum, the third aminosalicylate preparation, consists of 2 mesalamine molecules joined by an azo bond. As with sulfasalazine, the azo bond is cleaved by bacterial azoreductases in the gastrointestinal tract, allowing the drug to be released in the proximal colon. It is administered twice daily, with patients taking up to 8 capsules per day for a total dosage of 2 grams per day. Although each tablet of olsalazine has twice as much active ingredient as the mesalamine capsules, the efficacy is minimally enhanced. And now we will discuss balsalazade. Balsalazade, marketed as Colazal, is a combination product consisting of 5-aminosalicylic acid, marketed as mesalamine, the therapeutically active portion of the molecule, and 4-aminobenzoyl alanine, an inert moiety. The product is cleaved by bacterial azoreductases in the colon to release the active compound. Each capsule contains granules of balsalazade that are insoluble in acid and designed to be delivered to the colon intact. It is administered 3 times a day, up to 9 capsules per day, for a total dosage of 6.75 grams per day, equaling 2.4 grams per day of pure mesalamine. Currently it has been studied only for use in mild to moderate ulcerative colitis in both adults and children. Side effects and contraindications are similar to those of mesalamine. Pause the video and carefully scrutinize Table 31.4 summarizing an overview of agents used to treat inflammatory bowel disease before advancing to the next slide. Pause the video and carefully scrutinize Table 31.4 summarizing an overview of agents used to treat inflammatory bowel disease before advancing to the next slide. Pause the video and carefully scrutinize Table 31.4 summarizing an overview of agents used to treat inflammatory bowel disease before advancing to the next slide. Pause the video and carefully scrutinize Table 31.4 summarizing an overview of agents used to treat inflammatory bowel disease before advancing to the next slide. We will now discuss the adverse events. Mesalamine, olsalazine, and balsalazide are poorly absorbed from the gastrointestinal tract and thus are considered primarily topical agents, with limited systemic side effects and drug interactions. The major side effects of mesalamine include headache, malaise, abdominal pain, and diarrhea. Olsalazine has a similar side effect profile, but has a higher incidence of diarrhea than mesalamine. Initially, diarrhea may not be easily distinguished from an inflammatory bowel disease exacerbation, and therefore close monitoring of improvement of symptoms is essential. If the balsalazide capsules are opened and sprinkled in food, teeth staining may occur. In rare instances, mesalamine, olsalazine, and balsalazide have been associated with renal function impairment. Therefore, renal function should be monitored during therapy. Sulfapyridine is absorbed systemically. accounting for many of the side effects and drug interactions incurred by sulfasalazine. Common adverse effects include nausea, vomiting, photosensitivity, oligospermia, and skin discoloration, which may be tolerable for most patients. Severe adverse reactions associated with sulfasalazine include Stevens-Johnson syndrome, agranulocytosis, crystalluria, pancreatitis, and hepatitis, which may necessitate discontinuation of therapy. Sulfasalazine is known to decrease folate levels. Therefore, patients taking sulfasalazine should be supplemented with folic acid. Although drug interactions with sulfasalazine are limited, it may significantly decrease the effect of warfarin, marketed as Coumadin, and therefore close monitoring of the international normalized ratio is essential. Next we will talk about corticosteroids. Corticosteroids are used intermittently to treat acute inflammatory bowel disease exacerbations only. Corticosteroids allow for immunosuppression and prostaglandin inhibition when the disease fails to respond to aminosalicylate therapy. Corticosteroids may be used in conjunction with aminosalicylates, immunosuppressants, or biologic agents or as monotherapy to treat acute exacerbations. Corticosteroids with relatively quick onset of action and high glucocorticoid activity, such as prednisone, marketed as Orasone, or Deltasone, and methylprednisolone, marketed as Medrol, are desirable in the treatment of Crohn's disease or ulcerative colitis. Controlled-release oral budesonide, marketed as Entocort E.C., is a unique corticosteroid due to its long-acting formulation and limited potential for absorption from the gastrointestinal tract, thus theoretically leading to a localized effect in the gastrointestinal lumen with minimal systemic side effects. Oral budesonide has been used as the treatment of choice in patients with mild to moderate exacerbations of Crohn's disease in combination with aminosalicylates or as monotherapy. We will now discuss dosage. Doses equivalent to oral prednisone 40 to 60 mg d are initiated in patients with mild or moderate exacerbations of Crohn's disease or ulcerative colitis. A beneficial effect is usually seen with 7 to 10 days of therapy. Patients with mild to moderate exacerbations of distal ulcerative colitis can be treated with oral or rectal corticosteroids for approximately 4 to 8 weeks, after which drug dosages are tapered. Hydrocortisone is the only rectal corticosteroid enema formulation available for use in distal ulcerative colitis exacerbations. There are many tapering regimens that have been studied. The most common is a 5 to 10 mg weekly taper until a daily dose of 20 mg is reached, at which time the dose is tapered by 2.5 mg per week. In severe exacerbations, patients should receive 3 to 10 days of IV corticosteroid therapy and then switch to oral corticosteroid therapy for the remainder of the treatment period. See Table 31.4. We will now look at adverse events. Short-term corticosteroid use, that is shorter than 3 months, is associated with increased glucose levels, increased appetite, insomnia, anxiety, tremors, and increased fluid retention, leading to increases in blood pressure and electrolyte imbalances. Although discontinuation of therapy as a result of these side effects is not recommended with short-term corticosteroid treatment, routine monitoring is necessary. Long-term corticosteroid use is associated with decreased bone density, leading to osteoporosis, fat redistribution, leading to the characteristic buffalo hump, decreased prostaglandin synthesis, resulting in gastric and duodenal ulcers, hypertriglyceridemia, hyperkalemia, cataracts, and hirsutism. Therefore, long-term treatment with corticosteroids is not recommended. However, If patients are taking recurrent steroid therapy for recurrent exacerbations, monitoring for these side effects is imperative. Next we will look at interactions. Many corticosteroids are substrates of the cytochrome P450 isoenzyme 3A4, including prednisone, prednisolone, methylprednisolone, and budesonide. Therefore, agents that inhibit or induce this enzyme system, such as ketoconazole, clarithromycin, phenytoin, and pioglitazone, may alter the efficacy of the corticosteroid. Budesonide requires an acidic environment, pH below 5.5, to be released, so agents that inhibit acid production or neutralize acid in the gastrointestinal tract, i.e., histamine 2 antagonists, proton pump inhibitors, antacids, may limit the effectiveness of budesonide. Corticosteroids may also decrease the effectiveness of anti-diabetic and antihypertensive agents due to their ability to increase blood glucose levels and blood pressure. Next we will progress to the immunosuppressive agents. Immunosuppressive agents are used in inflammatory bowel disease as adjunctive treatment with aminosalicylates to induce and maintain remission if exacerbations occur while the patient is being tapered off corticosteroid therapy, or if frequent exacerbations occur with maximum dosages of aminosalicylates. IV cyclosporine is an exception. It is solely used to treat severe, acute exacerbations of ulcerative colitis when the patient is refractory to corticosteroids. Let's begin with azathioprine and 6-mercaptopurine. Azathioprine, marketed as Amuran, and 6-mercaptopurine, marketed as Puranthal, are antimetabolites that act as purine antagonists to inhibit the synthesis of protein, ribonucleic acid, RNA, and deoxyribonucleic acid, DNA. By doing so, azathioprine and 6-mercaptopurine decrease the production of various inflammatory mediators. Because 6-mercaptopurine is the active metabolite of azathioprine, these agents are similar in efficacy, side effect profile, and dosing frequency. See Table 31.4. Although these agents have a short plasma half-life of approximately 1 to 2 hours, both have active metabolites with long half-lives of 3 to 13 days, resulting in optimal therapeutic effects within 10 to 15 weeks of initiation of therapy. 6-mercaptopurine is metabolized by the enzyme thiopurine methyltransferase, TPMT. The activity of this particular enzyme varies in patients based on a genetic polymorphism. Therefore, patients may be at a higher risk for certain side effects if they have low enzyme activity. Thiopurine methyltransferase testing is available to identify patients who may have low enzyme activity and, in turn, may experience more side effects. These agents should be initiated during an acute exacerbation once the patient can tolerate oral medications to induce and maintain remission. Because of their slow onset of action, however, these agents are not effective for treating an acute exacerbation. The initial dosage of these agents is 50 mg per day in one dose. The dosage is increased every 2 weeks to a target dosage of 1 to 2 mg per kilogram per day for 6-mercaptopurine and 2 to 2.5 mg per kilogram per day for azathioprine. Because these agents are cleared by the renal system, dosages must be decreased in patients with creatinine clearance values under 50 ml, minimum. The dose for azathioprine and 6-mercaptopurine is usually decreased by 50% if the patient's creatinine clearance value falls below 50 ml per minute to decrease the risk of accumulation and unwanted effects. Although these agents have the potential to cause significant adverse events, they are in general well tolerated. These agents should not be used in pregnancy or in patients with active liver disease. Next we will discuss methotrexate. Methotrexate, marketed as Rumatrex, has a therapeutic effect similar to that of azathioprine and 6-mercaptopurine. However, it inhibits intracellular dihydrofolate reductase, which results in inhibition of purine synthesis and suppression of IL-1 production. Both the intramuscular and oral preparations of methotrexate are efficacious in the induction and maintenance of Crohn's disease remission, but similar efficacy has not been shown for ulcerative colitis. Doses of 25 mg per week injected intramuscularly or 5 mg orally 3 times a week have been effective in inducing remission in patients with steroid-dependent Crohn's disease after 12 to 16 weeks of therapy. At low doses, methotrexate is nearly completely absorbed when administered orally. Therefore, there is no foreseen benefit in using the intramuscular preparation over the oral formulation during normal gastrointestinal function. Methotrexate dosages must be adjusted based on renal function. Patients with creatinine clearance values less than 50 ml per minute should receive 50% of the normal dose. Methotrexate should not be prescribed to patients with active liver disease or pregnant women. Next we will look at cyclosporine. Cyclosporine, marketed as Sandomune, or Neoral, is reserved for the acute treatment of severe, steroid-refractory exacerbations of ulcerative colitis in hospitalized patients. Cyclosporine is a lipophilic, fungus-derived polypeptide that suppresses cell-mediated immunity by predominantly inhibiting IL-2 synthesis and release. Therapeutic effect is correlated with appropriate dosing. IV infusion of cyclosporine has been found effective at dosages of 4 to 8 mg per kilogram per day for ulcerative colitis. The use of cyclosporine in acute Crohn's disease exacerbations is reported to have variable results. Because of poor systemic absorption, oral cyclosporine should not be used. Improvement of symptoms with IV therapy usually occurs within 2 to 3 days, and the duration of therapy is usually 7 to 10 days. Next we will discuss their adverse events. Although azathioprine and 6-mercaptopurine are usually well tolerated, significant side effects may occur. These agents are associated with both allergic type and non-allergic type side effects. Allergic type side effects include pancreatitis, fever, rash, arthralgias, malaise, nausea, and diarrhea, which may occur regardless of dose. The main non-allergic type side effects include bone marrow suppression and hepatotoxicity, which appear to be dose-dependent. Pancreatitis may occur at any point in therapy and warrants discontinuation of therapy. The development of pancreatitis precludes the use of either 6-mercaptopurine or azathioprine in the future. Leukopenia and hepatotoxicity usually occurs during the initiation phase of therapy and may be managed by decreasing the dose. If a patient experiences side effects with either of these agents, it is not beneficial to switch the patient to the other agent. Side effects of methotrexate include hepatic cirrhosis and fibrosis, bone marrow suppression, pneumonitis, folic acid deficiency, and rash. Nausea and diarrhea are also reported, but they occur more frequently with the oral formulation. Bone marrow suppression and liver dysfunction are dose-dependent, and doses should be decreased in patients with these disorders. Folic acid should be administered concomitantly to limit folic acid deficiency. Cyclosporine is most associated with nephrotoxicity, hypomagnesemia, and hypertension. Risk factors for nephrotoxicity are high-dose treatment, long-term treatment, and advanced age. Discontinuation of cyclosporine may restore renal function within 2 weeks. Other side effects of cyclosporine include nausea, vomiting, opportunistic infections, paresthesias, tremor, and seizures. Opportunistic infections occur because of the drug's immunosuppressive effects and may be managed by appropriate antibiotic therapy. Next we will look at their interactions. Cyclosporine significantly interacts with various agents because of its metabolism through the cytochrome P4503A4 isoenzyme system. Enzyme inhibitors, such as erythromycin, marketed as ERIC, and ketoconazole, marketed as Nazoral, increase blood levels of cyclosporine by inhibiting its metabolism, whereas enzyme inducers, such as phenytoin, marketed as Dilantin, carbamazepine, marketed as Tegretol, and rifampin, marketed as Rifadin, decrease cyclosporine blood levels. Grapefruit juice increases blood levels of cyclosporine, which may increase the incidence of side effects. We will now discuss the antibiotics. The association between inflammatory bowel disease and infectious causes has led to the use of antibiotics. Because the exact organism has not been isolated, it is difficult to determine which antibiotics are most appropriate for treatment. In general, an antibiotic that acts against gram-negative and mycobacterium organisms with a low side effect profile and poor systemic absorption is desirable. Many agents have been studied, including broad-spectrum antibiotics, metronidazole, marketed as Flagyl, fluoroquinolones, antituberculars, and macrolides. However, based on the scarce published, controlled trials, mild to moderately active Crohn's disease appears to respond only to metronidazole and ciprofloxacin, marketed as Cipro. See Table 31.4. Beneficial effects of antibiotic therapy have not been replicated in patients with ulcerative colitis. Metronidazole showed efficacy in treating perianal Crohn's disease. Since then, however, a few studies have found beneficial effects of metronidazole in the treatment of mild to moderately active luminal and fistulizing Crohn's disease when used in combination with aminosalicylates or alone. The mechanism by which metronidazole alone exerts its beneficial effects in Crohn's disease is unknown, although it is thought that the immune-modulating effects are more prominent than the antibacterial effects. The normal dosage for treatment of mild to moderately active CD is 20 mg per kilogram per day. Once remission is attained, the dosage is titrated to 10 mg per kilogram per day for maintenance. The usual duration of therapy is up to 12 months, although remission is usually attained within 1 to 2 months. Although exacerbations of Crohn's disease have been reported with the discontinuation of metronidazole, long-term use is associated with significant side effects. Ciprofloxacin has also been studied for perianal and luminal Crohn's disease with mixed results. Ciprofloxacin covers gram-negative organisms and mycobacterium species as well as some gram-positive organisms and is usually well tolerated. Along with inhibiting DNA gyrase, which is its main antibacterial mechanism of action, ciprofloxacin also is reported to have immunosuppressive properties. A dosage of oral ciprofloxacin of 500 mg, twice daily, is as efficacious as 4 grams of mesalamine daily in preliminary trials. Remission is attained after approximately 6 weeks of therapy. Ciprofloxacin is contraindicated in children and pregnant women. Next we will look at adverse events of antibiotics. Short-term metronidazole therapy is associated with fairly benign side effects, including dry mouth, metallic taste, nausea, and vomiting. Abdominal distress, including cramping and diarrhea, may also occur, but these effects are difficult to distinguish from inflammatory bowel disease symptoms. Long-term use of metronidazole is associated with neurotoxic effects such as peripheral paresthesias, dizziness, pruritus, and vertigo that may warrant discontinuation of therapy. Ciprofloxacin is usually well tolerated. The most common side effects include nausea, diarrhea, dizziness, and rashes secondary to photosensitivity. However, long-term treatment may result in tendinitis and tendon rupture. And now we will progress to their interactions. Metronidazole is associated with severe nausea and vomiting, disulfiram effect, if taken concurrently with alcohol. Ciprofloxacin inhibits theophylline, marketed as slow-filan metabolism, so theophylline serum levels may need to be monitored with chronic ciprofloxacin use. Any divalent or trivalent cation, such as calcium or iron, may interfere with the absorption of ciprofloxacin, therefore at least a 4-hour dosing interval should be maintained between these agents. Next we will look at biological agents. Many biological agents are being investigated for the treatment of inflammatory bowel disease, including TNF inhibitors, growth factors, lymphocyte inhibitors, and transcription inhibitors. Currently infliximab, marketed as Remicade, adalimumab, marketed as Humira, and certolizumab pegol, marketed as Cimzia, all of which are TNF inhibitors, are the only biological agents approved for the treatment of severe refractory luminal Crohn's disease. Infliximab is also indicated for maintaining remission in Crohn's disease as well as treating ulcerative colitis and fistulizing Crohn's disease. The gastrointestinal mucosal tissues of patients with active Crohn's disease are found to overexpress numerous immunologic cytokines, including TNF. Biological TNF-alpha is a pro-inflammatory cytokine that stimulates the expression of various immunologic cytokines, such as IL-8 and interferon G. The TNF-alpha inhibitor agents produce their effect by neutralizing soluble forms of TNF-alpha and competitively inhibit its binding to the TNF receptor. In addition, TNF-alpha inhibitors may also induce apoptosis of activated monocytes. Infliximab is a synthetically derived immunoglobulin G monoclonal antibody consisting of 25% murine antibodies and 75% human antibodies. See Table 31.4. Infliximab is available only as an IV solution, and it is administered at a dosage of 5 mg per kilogram over a minimum of 2 hours. A single infusion dose at baseline, week 2, and week 6 is administered for the treatment of an acute exacerbation. Infusions every 8 weeks are used to maintain remission. The infusions may be delivered in an inpatient or a monitored outpatient setting. Repeated doses of the product may increase the risk of immunogenicity and infusion-related reactions due to the murine component of the product. Infliximab has not been adequately studied in pregnant women, so caution should be used when prescribing it in pregnancy as well as in patients with heart failure. Adalimumab is also a TNF-alpha inhibitor. However, it is a fully humanized IgG monoclonal antibody that binds specifically to human TNF. In general, fully humanized monoclonal antibodies are associated with less immunogenicity and infusion-related reactions. Adalimumab is administered as a subcutaneous injection every 2 weeks and may be increased to once weekly if necessary. See Table 31.4. In addition to patients with Crohn's disease who are naive to TNF-alpha inhibitors, adalimumab is effective in patients with Crohn's disease who may not have responded to infliximab. It has not been well studied in ulcerative colitis or fistulizing Crohn's disease or in children with ulcerative colitis or Crohn's disease. Certolizumab pegol is also a TNF-alpha inhibitor. However, it is not a full monoclonal antibody. Certolizumab pegol consists of only the Fab fragment of human-derived IgG, which is attached to polyethylene glycol. Since certolizumab pegol does not contain certain regions of a full antibody, it cannot cause antibody-dependent cell cytotoxicity or induce apoptosis as with infliximab or adalimumab. The polyethylene glycol portion of the product allows for a longer duration of action and thus a longer duration between injections. Certolizumab pegol is administered in 2 subcutaneous injections initially and weeks 2 and 4. For those who elicit a clinical response, certolizumab pegol may be used every 4 weeks to maintain remission. See Table 31.4. It has not been studied in the treatment of ulcerative colitis or fistulizing Crohn's disease or in children. Next we will discuss their adverse events. The primary side effects associated with TNF-alpha inhibitors are injection site-related reactions, which include erythema, itching, and swelling. Less common but significant side effects include the development of heart failure, tuberculosis, TB, hepatitis B reactivation, opportunistic infections, lymphoma and other malignancies, hepatotoxicity, vasculitis, and pancytopenia. Patients should be tested for latent TB and treated accordingly prior to treatment with TNF-alpha inhibitors. TNF-alpha inhibitors are contraindicated in patients with active TB and should be used cautiously in patients with heart failure. Infliximab is also associated with infusion-related reactions, including transient hypersensitivity reactions, flushing, headache, dyspnea, rash, and fever, possibly secondary to the murine component of the product. These side effects may be managed by pretreating patients with antihistamines, acetaminophen, and/or corticosteroids. In addition, mild to moderate infusion reactions may be managed by decreasing the infusion rate. Next we will discuss the drug interactions. Extensive drug interaction studies have not been performed to date, but due to their ability to alter the immunologic response, TNF-alpha inhibitors should not be administered along with live vaccines. Commonly, TNF-alpha inhibitors are administered to patients who are also taking immunosuppressive agents. The administration of other immunosuppressant agents, e.g., azathioprine, methotrexate, with these agents has been shown to be beneficial by decreasing the risk of immunogenicity, development of autoantibodies, and decreasing infusion-related reactions, according to Lichtenstein and colleagues in 2009. No significant drug interactions have been reported when TNF-alpha inhibitors are given with conventional IBD therapy. Pause the video and carefully scrutinize Table 31.5 summarizing the recommended treatment options for Crohn's disease and ulcerative colitis before advancing to the next slide. We will now discuss selecting the most appropriate agent. For many diseases and disorders, there are drug treatment protocols that make clear distinctions between first-line, second-line, and third-line therapies. However, in inflammatory bowel disease, the decision to use one therapeutic modality over another is based on the location of the inflammation, the severity and extent of disease, the patient's tolerance of the therapy, patient compliance, and cost, as shown in Table 31.5. The American College of Gastroenterology has developed guidelines for managing Crohn's disease and ulcerative colitis, according to Lichtenstein and colleagues in 2009, and according to Kornbluth and Sacker in 2010. Let's briefly look at Crohn's disease. Mild to moderately active luminal Crohn's disease is typically treated with oral aminosalicylates alone or in combination with antibiotic therapy. However, monotherapy with budesonide has also been used with good results, especially in patients with ileal or right colonic disease. Oral agents are chosen over rectal agents because of the random presence of Crohn's disease along the entire gastrointestinal tract. Patients may be maintained on aminosalicylates or antibiotic therapy for months to years, but the goal is to taper the patient off the medication as soon as possible once remission is attained. Budesonide is indicated for 3 months to maintain remission in Crohn's disease. Treatment of moderate to severe Crohn's disease usually consists of combination therapy with aminosalicylates and corticosteroids. Corticosteroid therapy is used acutely on a short-term basis for patients with moderate to severe disease to attain remission. Because of their high side effect profile, steroids are not used chronically to maintain remission. Oral agents may be used for patients with moderate to severe disease. The typical duration of therapy is 4 to 12 weeks at the full dose, and then doses are tapered by 5 to 10 mg weekly until discontinued. If patients have had multiple exacerbations and are steroid refractory or have fistulizing disease, TNF inhibitors may be indicated. Severe to fulminant disease requires definitive drug therapy in addition to substantial supportive care measures due to poor oral absorption and rapid gastrointestinal transit time. Oral therapy, including aminosalicylates, should not be administered until the patient can tolerate oral alimentation. IV corticosteroids are indicated to decrease inflammation and induce immunosuppression. For patients with moderate to severe or severe to fulminant disease whose disease is refractory to corticosteroids, either oral or IV, biological agents are an option. Supportive care measures, such as IV fluids, bowel rest, and parenteral nutrition, should also be considered. Therapy to maintain remission should be considered in patients who have frequent exacerbations, or who are steroid dependent. Immunosuppressive agents, including azathioprine, 6-mercaptopurine, methotrexate, and the TNF-alpha inhibitors, may be used with aminosalicylates to maintain remission in patients whose disease is refractory to aminosalicylate monotherapy. The immunosuppressant agents may take effect after 10 to 12 weeks. Therapeutic effect should be seen within 8 weeks of administration of the TNF-alpha inhibitors. Patients may be maintained on these agents for months to years, but the goal is to taper the patient off the medication as soon as possible due to the significant side effects. Antibiotics, specifically metronidazole and ciprofloxacin, have proved beneficial in maintaining remission of perianal and fistulizing Crohn's disease with long-term use, as shown in Figure 31.1. We will now progress to ulcerative colitis. For ulcerative colitis, guidelines specify various treatment approaches depending on the severity and location of disease. Distal colitis, identified as lesions below the splenic flexure, may be treated with oral, rectal, or IV agents depending on the severity of disease. Rectal agents should not be used in patients with extensive colitis due to the location of disease. The decision to use systemic or local preparations for distal colitis largely depends on patient preference. However, topical products allow for less systemic absorption, less frequent dosing, and a quicker onset of effect, as shown in Figure 31.2. Treatment of mild ulcerative colitis is best achieved with the use of aminosalicylates. The combination of oral and rectal aminosalicylates is more effective than either therapy alone. Corticosteroids may be used concurrently with aminosalicylates for moderate ulcerative colitis exacerbations. Depending on the severity of the exacerbation and the location of the lesions, either rectal or oral preparations may be appropriate. Severe exacerbations may require hospitalization. Discontinuation of oral and topical therapy due to rapid gastrointestinal transit time and the initiation of IV corticosteroid therapy are standard. If improvement in the condition is not seen in 7 to 10 days with IV corticosteroids, IV cyclosporine or IV infliximab may be considered. The use of IV cyclosporine is reserved for hospitalized patients who have not responded to IV steroids. Infliximab may be initiated in an outpatient or inpatient setting in patients with severe exacerbations after an adequate trial of steroids. Surgery may be considered in patients whose disease fails to respond to drug therapy. The management of fulminant exacerbations is very similar to that of severe exacerbations, but the decision to perform a colectomy is considered at a much earlier stage for fulminant exacerbations. Along with definitive therapy, supportive measures including bowel rest, IV fluids, and adequate nutrition should be considered for those with severe and fulminant exacerbations. For those with frequent exacerbations or steroid dependence, immunosuppressive agents such as 6-mercaptopurine and azathioprine should be considered to induce and maintain remission. Typically, immunosuppressive agents are initiated after the patient can tolerate oral medications and are initiated along with aminosalicylate and corticosteroid therapy. The goal is to taper the corticosteroid and continue the aminosalicylate, along with the immunosuppressive therapy for maintenance of remission. Methotrexate has not been adequately studied in patients with ulcerative colitis and therefore is not recommended. Antibiotic therapy has not been shown to improve ulcerative colitis symptoms. Pause the video and carefully scrutinize Figure 31.1, which is a treatment algorithm for active luminal Crohn's disease, before advancing to the next slide. Pause the video and carefully scrutinize Figure 31.2, which is a treatment algorithm for active ulcerative colitis disease, before advancing to the next slide. Next we will discuss drug selection. Sulfasalazine was considered the first-line aminosalicylate because of its remarkable efficacy, low cost, and availability in oral liquid and tablet preparations. However, it must be taken 4 times a day and causes significant adverse drug reactions. For maximum therapeutic benefit, 4 to 8 grams per day is necessary. So patients must take up to 16 tablets or 32 teaspoonfuls daily. In addition, immediate-release sulfasalazine has activity limited to the colon, making it less effective in conditions affecting the upper gastrointestinal tract. Mesalamine has emerged as the aminosalicylate of choice because of its availability in many formulations, dosing frequency, and its low side effect profile. But it is more expensive than sulfasalazine. Depending on the oral formulation and the severity of the disease, patients may need to take 6 to 16 pills daily to attain maximum therapeutic benefit. Normal dosages of oral mesalamine are 2 to 4.8 grams per day. Olsalazine and balsalazide are not used as often because of their added cost without any significant clinical benefit. The ideal corticosteroid for treating inflammatory bowel disease would have high glucocorticoid activity, a low side effect profile, targeted delivery to the diseased site, and would be poorly absorbed from the gastrointestinal tract, allowing for localized activity. Oral budesonide, marketed as Entocort, is approved specifically for the acute treatment of inflammatory bowel disease due to its ideal characteristics, but due to its increased cost, other corticosteroids are used frequently to treat an acute exacerbation. The choice of steroid depends on the route of administration, onset of action, and glucocorticoid versus mineralocorticoid potency. In general, agents with more glucocorticoid activity are preferred over mineralocorticoid steroids because they have better anti-inflammatory action. Oral agents are used primarily in patients with localized or generalized disease with mild to moderate exacerbations. Rectal formulations are reserved for patients with mild to moderate exacerbations of distal ulcerative colitis disease, and IV treatment may be initiated in patients with severe exacerbations of Crohn's disease or ulcerative colitis. The use of immunosuppressive agents varies based on the type of inflammatory bowel disease and the severity of disease. Cyclosporine is reserved for the acute treatment of severe ulcerative colitis exacerbations because of the high cost of therapy and high incidence of severe side effects. Because of a lack of comparative trials of methotrexate and azathioprine or 6-mercaptopurine, it is difficult to determine which agent would be considered first line. However, there are more data to support the use of azathioprine or 6-mercaptopurine than methotrexate for Crohn's disease and ulcerative colitis. Azathioprine and 6-mercaptopurine are equally efficacious, with similar pharmacokinetic, adverse drug reaction, and cost profiles, so no great distinction can be made between the two. The main distinction between methotrexate and the other two agents is its availability as an intramuscular injection and its dosing schedule. The infrequent dosing schedule of oral and intramuscular methotrexate may promote either compliance or non-compliance with the medication, depending on the patient. Combining these agents for the induction and maintenance of remission is not recommended because of overlapping side effect profiles and lack of improved efficacy data. If antibiotic therapy is warranted, metronidazole or ciprofloxacin is an acceptable agent, depending on patient-specific factors. There are a few differences among the TNF-alpha inhibitors that may make one agent more favorable in certain patients than others. Infliximab is the only product that is approved for the treatment of patients with severe, refractory ulcerative colitis or fistulizing Crohn's disease. Therefore, it remains the best option in these patients at this time. For patients with luminal Crohn's disease who are able to self-inject themselves, either adalimumab or certolizumab pegol may be an option. Adalimumab and certolizumab pegol are available as a pre-filled syringe for convenience. However, adalimumab is administered subcutaneously as one injection every 2 weeks, whereas certolizumab pegol is administered subcutaneously as 2 injections every 4 weeks. Infliximab may also be used for luminal Crohn's disease. However, since it is an IV infusion, it must be administered by a healthcare practitioner in a monitored setting. Also, since adalimumab and certolizumab pegol are fully humanized monoclonal antibodies, the risk of infusion reactions, hypersensitivity, and development of autoantibodies are less likely than with infliximab. Adalimumab has also been found effective in patients who have previously not responded to infliximab, according to Sandborn and colleagues in 2007. We will now discuss special population considerations. Let's begin with pediatrics. Inflammatory bowel disease is typically diagnosed early in life, usually during the 2nd or 3rd decade, leading to significant implications of inflammatory bowel disease in the pediatric population. Treatment must be aggressive to limit the potential for nutritional deficiencies, leading to stunted growth, malnutrition, and anemia. However, many of the medications lead to untoward effects or are not well studied in pediatrics. The use of long-term corticosteroids may lead to growth abnormalities, whereas ciprofloxacin use is contraindicated in children because it can cause arthropathy, resulting in poor bone formation. Infliximab is indicated for inducing or maintaining remission of Crohn's disease in children older than age 6. The safety and efficacy of infliximab is not well studied in children with ulcerative colitis. Certolizumab pegol has not been studied in children. Adalimumab has been studied in children with Crohn's disease, but is not indicated in children at this time. Supplemental therapy including proper nutrition, iron therapy, and adequate hydration should also be considered to maintain growth and general health. Treating inflammatory bowel disease in children involves aggressively managing the condition as well as the side effects with the limited options. Next we will discuss pregnancy. The fertility rate in women with inflammatory bowel disease is similar to the general population, but spontaneous abortions, stillbirths, and developmental defects are more common in pregnant women with active disease. Therefore, inflammatory bowel disease should be treated aggressively in pregnant women to limit dehydration, anemia, and nutritional deficiencies that could adversely affect fetal outcomes. However, treatment options are limited for pregnant women due to the risk of teratogenicity or unwanted effects on the fetus. Methotrexate is absolutely contraindicated in pregnancy and lactation due to its potential for spontaneous abortions and teratogenicity. Data are controversial regarding the use of mercaptopurine and azathioprine during pregnancy. If either of these agents is necessary during pregnancy, an azathioprine dosage of 2 mg per kilogram per day or less is recommended to limit pancytopenia in the fetus. Azathioprine and mercaptopurine are contraindicated during nursing due to the potential of fetal immunosuppression. The use of cyclosporine should be reserved for severe refractory cases because it can cause growth retardation. The TNF inhibitors for inflammatory bowel disease are all pregnancy category B. However, there are not adequate studies in humans to determine their safety in pregnancy. Therefore, they should only be reserved in patients with severe refractory disease whereby the benefits significantly outweigh the potential risks such as immunosuppression. Ciprofloxacin and metronidazole should also be avoided in pregnancy and lactation because they can cause fetal malformations. Corticosteroids may be used at the lowest doses possible to induce remission for the shortest period of time to limit adrenal suppression of the fetus. Women taking sulfasalazine should be given higher dosages of folate, 2 mg per day, because sulfasalazine interferes with folate absorption. Preconception counseling is imperative to discuss the condition, lifestyle changes, nutritional issues, and treatment options with the patient. Special attention should be given to maintaining body weight before conception and preventing exacerbations during pregnancy. Next we will discuss monitoring patient response. Various parameters must be monitored to detect efficacy and toxicity associated with therapy. Efficacy parameters include signs and symptoms of Crohn's disease and ulcerative colitis, which are well defined in the working definition of Crohn's disease activity and criteria for severity of ulcerative colitis. Nutritional parameters such as weight, albumin, vitamin B12 levels, iron levels, and transferrin saturation should also be followed. Mental status and quality of life issues such as frequency of social interactions, attendance at work, and completion of activities of daily living all may indicate effectiveness of therapy. Although there are no definitive guidelines for the frequency of monitoring, it is important to monitor these endpoints when adjustments are made in drug therapy or when exacerbations occur. Specific monitoring of drug toxicities is imperative for all pharmacologic agents. CBC and liver function tests should be performed periodically to detect asymptomatic, undesired reactions in patients taking sulfasalazine. In addition, renal function, i.e., blood urea nitrogen, or serum creatinine, should be monitored routinely with aminosalicylates to identify nephrotoxicity. Corticosteroid treatment is associated with significant drug toxicities, but most occur with long-term use. In general, short-term corticosteroid treatment does not require intense monitoring. However, patients who have uncontrolled hypertension or who are glucose intolerant must have their blood pressure or fasting blood glucose level monitored periodically while taking corticosteroids. For patients taking corticosteroids on a long-term basis, baseline tests including a lipid panel, electrolytes, and fasting blood glucose studies should be performed every 6 to 12 months. A baseline bone density scan may be judicious and may be repeated yearly. Azathioprine and 6-mercaptopurine are both associated with significant side effects, so it is important to require a baseline CBC with differential and serum creatinine, amylase, and liver function tests. The CBC should be monitored more frequently during the initiation of therapy, every 1 to 2 weeks for the first 3 months, and then less frequently, every 3 to 6 months, for the duration of therapy. Liver function tests should be monitored every 3 months for the first year or until a stable dosage has been achieved, then every 4 to 6 months for the duration of treatment. Creatinine clearance is an important parameter in guiding the dosing regimen of azathioprine or 6-mercaptopurine, so serum creatinine and creatinine clearance should be monitored annually if renal function is stable and more often if fluctuations in dosages or renal function occur. Amylase is not routinely ordered, but it may be checked upon patient complaints due to the risk of pancreatitis. During the initial phase of methotrexate therapy, CBC and liver function tests should be performed every 2 to 4 weeks. If methotrexate therapy is continued beyond 16 weeks, CBC and liver function tests should be monitored every 4 to 8 weeks for the duration of therapy. Dosage adjustments must be made based on creatinine clearance, so serum creatinine must be monitored at baseline and at every dosage change. If renal function is stable, serum creatinine should be monitored annually at a minimum. Liver biopsies may be obtained once yearly if the patient is taking methotrexate, although formal recommendations have not been made. IV cyclosporine therapy requires daily monitoring of cyclosporine blood levels, that is 200 to 400 nanograms per milliliter, blood urea nitrogen, serum creatinine, and blood pressure. Although cyclosporine is extensively metabolized by the liver, it is eliminated by the kidneys and is highly associated with permanent renal dysfunction. Therefore, renal function must be monitored closely. Dosages should be adjusted daily based on renal function and cyclosporine blood levels. Opportunistic infections may occur with high-dose cyclosporine use, so CBC, signs of infection, and temperature should also be monitored daily. TNF-alpha inhibitors are associated with many side effects. However, most do not occur commonly. Due to the rare incidence of serious side effects, routine laboratory monitoring is not indicated. However, a heightened awareness of the clinical symptoms of adverse events is warranted. Patients and healthcare professionals should routinely monitor for symptoms of heart failure, vasculitis, TB, infection, hepatotoxicity, and lupus-like syndrome. Autoantibodies to the TNF-alpha inhibitors are known to develop and can be monitored via serum levels. Patients who develop autoantibodies may be more likely to develop lupus-like syndrome or have reduced efficacy with the agents, according to West and colleagues 2008. Routine administration of TNF-alpha inhibitors and concomitant administration of immunosuppressants limit the development of autoantibodies. Metronidazole and ciprofloxacin do not require significant drug monitoring, but long-term antibiotic treatment may lead to superinfection, so signs and symptoms of infection should be noted and treated. Patients receiving metronidazole therapy should also be monitored for peripheral paresthesias. Next we will discuss patient education. Let's begin with drug information. Patients and caregivers need to understand that uncontrolled inflammatory bowel disease may affect quality of life, psychological well-being, and general physical health, so adherence to medication therapy is imperative. In addition, due to the increased gastrointestinal transit time during an exacerbation, patients may not fully absorb oral medications for any of their conditions, which may lead to poor control of their other conditions during an inflammatory bowel disease exacerbation. Patients should swallow the enteric-coated sulfasalazine or mesalamine tablets and capsules whole so that the dosage form can penetrate the affected area. Sulfasalazine can discolor body fluids, e.g., urine and tears, which may stain clothing and contact lenses. When taking metronidazole, patients must abstain from alcohol to avoid severe nausea and vomiting. Often patients request chronic corticosteroid therapy because of its beneficial results, but these patients need to be informed of the long-term complications of corticosteroids and should be advised regarding other medications that may be more appropriate for chronic therapy. Patients also need to be aware that immunosuppressants, azathioprine, 6-mercaptopurine, methotrexate, take 10 to 15 weeks to take effect. Therefore, adherence to the medication regimen is imperative even though resolution of symptoms will not be apparent until weeks later. Although the TNF-alpha inhibitors are quite efficacious for inflammatory bowel disease, patients must be made aware of the significant risks associated with them. In addition, if patients are prescribed either adalimumab or certolizumab pegol, they must be instructed on the proper self-administration of a subcutaneous injection as well as sterile technique and safe needle disposal. Next we will discuss patient-oriented information sources. Along with their healthcare professionals, there are many other resources available for patients who are seeking information on inflammatory bowel disease. A local support group may be a good resource for patients having trouble dealing with the illness. Many local hospitals as well as the Crohn's and Colitis Foundation of America organize support groups for patients with inflammatory bowel disease. For general medical information regarding inflammatory bowel disease, the following websites offer helpful patient-specific information. 1. AGA, www.gastro.org. 2. American College of Gastroenterology, www.acg.gi.org. 3. Crohn's and Colitis Foundation of America, www.ccfa.org. 4. Medline Plus, www.nlm.nih.gov/medlineplus/5. National Institute of Diabetes, Digestive, and Kidney Diseases, www.niddk.nih.gov. Next we will discuss preventive care. Let's begin with nutritional status. Nutritional status is a significant issue for patients with active inflammatory bowel disease and those with surgical resections. Patients with inflammatory bowel disease are at risk for stunted growth, malnutrition, dehydration, weight loss, iron deficiency anemia, macrocytic anemia, osteopenia, and other conditions. Nutrient deficiencies of iron, vitamin B12, zinc, folate, calcium, and vitamin D may result from decreased oral intake, malabsorption, excessive losses, hypermetabolism due to infection, or drug-induced side effects. Concurrent administration of folate with methotrexate and sulfasalazine and administration of calcium and vitamin D with corticosteroids are recommended to limit the potential for nutritional deficiencies. Also, due to folate deficiencies, patients with inflammatory bowel disease are at risk of hyperhomocystinemia, resulting in an elevated potential for thrombosis. Vitamin B6 and vitamin B12 supplementation is recommended to decrease homocysteine levels. Folate supplementation is especially important in women of childbearing age. Many special dietary agents have been studied in patients with inflammatory bowel disease with varying results. Diets high in short-chain fatty acids are associated with a small decrease in disease severity, potentially due to an anti-inflammatory effect. Fish oils have been associated with a decreased frequency of exacerbations, potentially due to their anti-inflammatory properties. An area of new research interest is the role of probiotics such as lactobacillus and Saccharomyces in the treatment of inflammatory bowel disease. By altering the gastrointestinal flora, it is theorized that probiotic agents assist with controlling inflammatory bowel disease exacerbations. Enteral and parenteral routes of nutrition have been routinely used to improve the nutritional status of inflammatory bowel disease patients. In general, enteral nutrition is preferred due to the complications of infection, thrombosis, and pancreatitis associated with parenteral nutrition. Along with correcting nutritional deficiencies, enteral nutrition has also been studied as a primary treatment measure in combination with aminosalicylates. Parenteral nutrition, however, is advocated in severe exacerbations when bowel rest is in order for proper healing of the inflammatory bowel disease. In general, nutritional supplementation plays a large role in the management of inflammatory bowel disease. Depending on the severity of weight loss and general health status of the patient, a combination of vitamin and mineral supplementation along with either enteral or parenteral nutrition should be advocated. We will now discuss vaccination. Vaccination status in patients with inflammatory bowel disease is critical. Since inflammatory bowel disease is an autoimmune disease and treatment is focused on immunosuppressant therapy, patients are at higher risk for developing infections. Vaccination records should be reviewed routinely and updated as necessary. Patients taking TNF inhibitors are at risk for hepatitis B reactivation. Therefore, screening patients prior to therapy may be prudent. Patients taking an immunosuppressant cannot receive live vaccines. However, they are eligible for inactivated vaccines such as influenza, pneumococcal, meningococcal, tetanus, and hepatitis B, according to Kornbluth and Sacker in 2010. Next we will talk about cancer screening. Patients with inflammatory bowel disease are at a higher risk for colorectal cancer, according to Eden and colleagues in 2001. The extent of the risk depends on the extent, course, and duration of the disease in a particular individual. Due to the increased risk, patients with inflammatory bowel disease for a minimum of 8 years should be screened for colorectal cancer with a colonoscopy and biopsy. Although the data are conflicting as to how often patients should be screened, the American College of Gastroenterology recommends either annually or biannually, according to Kornbluth and Sacker in 2010. Lastly, we will discuss complementary and alternative therapies. Alternative therapies are used by many patients with inflammatory bowel disease. According to one study, 47% of patients with inflammatory bowel disease had used alternative therapies for their condition. The most common alternative therapies used were acidophilus and flaxseed, along with massage therapy, even though data are limited regarding the efficacy of these agents in inflammatory bowel disease. Omega-3 fatty acids have also been studied for use in inflammatory bowel disease. The National Institutes of Health reported variable results with the use of omega-3 fatty acids for inflammatory bowel disease, so widespread use cannot be endorsed at this time, according to the Agency for Healthcare Research and Quality in 2004. Surgical options are considered in patients who are at risk for a further decline in physical health and quality of life resulting from frequent exacerbations that are unresponsive to conventional therapy. Surgical options include proctocolectomy for ulcerative colitis and a variety of ostomy procedures for patients with Crohn's disease, depending on the location of disease, as shown in Table 31.6. Proctocolectomy, the removal of the entire colon and rectum, is a curative intervention for ulcerative colitis. However, surgical procedures for Crohn's disease are not curative, because exacerbations may recur in existing areas of the gastrointestinal tract, and surgery is used only to maintain remission. For patients who have undergone surgery, the practitioner must pay close attention to general drug therapy issues. Because of the resection of the gastrointestinal tract, these patients have issues similar to those of patients with short bowel syndrome. Rectally administered agents such as suppositories and enemas are ineffective in patients with any type of lower gastrointestinal resection. Depending on the site of resection, sustained-release agents and medications targeted to specific areas of the gastrointestinal tract also are ineffective in general. Thank you.